I'm Dr. Amol Gupta, and I want to thank you for joining me on another episode of the Medicine Mentors, where we interview masters in medicine, leading physicians at the top universities across the United States, to learn from their experiences and derive key insights, traits, and best practices that can guide medical students and residents. Today we have a very special guest, Dr. Jillian Catalanotti. Dr. Catalanotti is an associate professor of medicine and of health policy and management at the George Washington University. As director of the internal medicine residency program, she's responsible for 110 residents in 2 programs and 55 fellows in 12 fellowship programs. Dr. Catalanotti has co-designed and co-directs the Underserved Medicine and Public Health Concentration, a 2-year longitudinal program for residents with a special interest in working with underserved populations. She has multiple publications in high-impact journals and was in fact the first author on the AAIM Consensus Statement on Service and Education. Dr. Catalanotti, I'm honored that you have given us an opportunity to learn more about your life story and experiences.
Thank you so much. I'm really excited to be here.
Can you walk us through a little bit of your journey? What were some of the values that you imbibed early on in your life, and then how did they shape your journey?
Sure. So I'm from Long Island, New York, and I have a very close family. I have 2 sisters and my parents, and we were fortunate to live about 15 minutes away from my grandparents. So we were all sort of the kind of family where everybody knows everybody's business and everyone's giving everyone advice, both welcome and unwelcome at all times. But we're not a medical family. I am the only physician in my family. I bring that up because I actually would say some members of my family are anti-medical individuals. I distinctly recall a story my grandmother shared where an ambulance came to her home to pick him up when he was ill, and they wouldn't even touch him to allow him in the ambulance. And my grandmother had to assist with doing that. And I really remember just that entire experience and thinking, wow, I think maybe I could do this better, and maybe I could be a doctor that my family would like. So it was always sort of intriguing to me, sort of why it was that it felt like to want to be a doctor, you'd have to have all these amazing traits. But then somehow my family's experiences with doctors were that they didn't really like them or trust them. I distinctly recall the day that I got into medical school and I called my grandmother to let her know the great news that I had been accepted to medical school. And she said, "Jill, I'm so proud of you. And you should know that I hate all doctors." And it was particularly striking to me because it was actually the only time I think I've ever heard my grandma use the word hate. She just was a very positive person and never said that. So anyway, I think I had a different preconceived notion about what it meant to be a physician compared to some of my classmates in medical school. But suffice it to say, went on to college, when I moved away from my family and went to Yale, as you said, and majored in biology and absolutely loved it. And I remembered thinking, well, what do you do if you love biology, but you don't like doctors? And it was sort of through that and through some volunteer experiences, I went to local middle schools and taught sex education to girls. And I realized, what, this is what I want to do. I want to teach people about their health, and I want to help them to figure out how they can maintain their own health. So decided to go to medical school, had that conversation with my grandmother where I learned she hated all doctors, but she would still love me. Yeah, I had an amazing experience in medical school. I remember just liking absolutely every subject. I remember really liking every rotation, but it was clear to me that I did not like the operating room, and that wasn't news to me. I suspected I wouldn't like the operating room. And it was really kind of, I think, as a result of that I realized being a generalist physician made a lot of sense because I just loved everything and I couldn't think of cutting any part of that out of my career.
How have you found, or certain tools or tips that you can share with us today, that doctors can imbibe and start to practice to help bridge that gap between the mistrust, the trust that the patients have, so we can follow through with the recommendations that we give them?
We'll all at some point have a patient who challenges that, right? Who makes you feel frustrated, who makes you want to lose your patience. And then I try to step back and say, this is someone's mother. This is someone's sister. This is someone's daughter. And how would I want to treat my mother? How would I want my sister to be treated in this interaction? And I find it helps me to reset if I do feel that I'm becoming frustrated in any kind of clinical interaction. Because I do think if it's, if you keep the patient in the center of that and say, I'm going to respect and I'm going to really care for this person, then I can sort of help to say, well, how will I tailor the advice that I'm giving that will meet them where they're at and prioritize what's important to them to prioritize.
Talk to us a little bit about the role of service and the mentality of service as physicians?
So I found that, even throughout high school, throughout college, throughout medical school, the things that I was absolutely the happiest doing were, things that I guess for the most part were considered extracurricular because they were community service activities. I think for me, a big part of my career, when I reflect on who are the patients that I most love to treat, it really has been patients who are underserved, who have other challenges that are going to make perhaps the complex plan that I try to give them to care for their health a really hard plan to carry out and potentially a hard plan to prioritize in their life. And I think it's a real privilege to get to learn that about people and to get to help them brainstorm, how can they sort of achieve this when they obviously have competing priorities.
What do you remind yourself, or any tools that you use to put yourself back in the state of mind of why I became a doctor in the first place?
I think the best tool for doing that is talking to our patients and learning their stories. I think for the most part, it's pretty hard to speak to a hospitalized patient and not hear that this is not where they want to be right now, and they have other great things going on in their life that they would love to get back to, and remind you that they are a human being who is connected to other human beings. And, this is one stop on their journey, but it's certainly not their favorite stop. They really want to get back to the rest. You're seeing them in the hospital and it's their birthday, or you're seeing them in the hospital and it's their wedding anniversary or a holiday or things like that. And one of the things that I think is great as a physician is to recognize those days. First of all, to recognize that it's obviously not ideal for the patient. You're not the person they want to be celebrating with, but to acknowledge that and then to actually try and celebrate it with them. Although maybe we're not the people they want to be celebrating those things with. If we're the ones they're stuck with, we should celebrate those things with them.
You mentioned you have a lot of mentors in your life. Can you talk to us a little bit about how you found your mentors and the role that they played in your life?
When I was, reflecting on mentorship and thinking about this interview, my biggest mentor that comes to mind for me in my career is Dr. Carol Bates, who was my primary care program director at Beth Israel Deaconess Medical Center during residency. It started because on my interview day at Beth Israel Deaconess, they had a teaching conference that was the kind of session where they were presenting a case on lupus and they would call on different specialists to say, give us the nephrologist view of so-and-so thing, and here's what's the rheumatology view, and et cetera. And they actually called on Dr. Bates and they said, as a primary care physician, tell me about what we need to be thinking about in terms of surveillance and primary care for a patient with lupus. And she answered so eloquently, and it was so clear that she not only knew her stuff, but she was just respected by everyone in that room. I walked away from that interview day thinking, I really need to meet that doctor and I really need to make her a role model and a mentor for me, because most people who are interested in primary care probably have seen the experience of thinking that it's not always sort of respected within university settings and things. And so it was so striking to me to see that. And I couldn't shake it, really. Every other residency program that I interviewed at, I kept thinking but I want to meet that woman, Dr. Carol Bates, and her mentee. So fortunate for me, matched there and did get to work very closely with Dr. Bates. And I think really she embodied what I said earlier about, both loving your learners and loving your subject. And she was a mentor to me, both in terms of clinical knowledge and just discussing cases with her and discussing patients. She was a mentor to me in terms of, I was really unsure what my career was going to look like. I actually did not intend to enter academic medicine. I was planning to be a primary care physician at a community health center. So I started interviewing for all sorts of different jobs. And it was actually Dr. Bates who helped me to think through those different options. And when it was clear that my husband had to move to DC, she was able to reach into her mental Rolodex and pull out 3 names of physicians in DC that I could call, and has really just continued to be someone who I reach out to. And we touch base at least once or twice a year. And, when I was offered the job of residency program director, it was Dr. Bates who I called first to help me think through it. So I think there are mentors like that who, when you find one, it's just the most fortunate thing that it's someone who is just willing to be with you in the long term and really help you to think and reflect about what's important to you and, what are your goals and how can you meet them. I think other than that, along the way, there are so many different kinds of mentors and people who mentor you on different things. So I think I would encourage your listeners, don't be intimidated by that first story I told about Dr. Bates being such a large mentor, because there are lots of people along the way who can mentor you on individual things you're trying to achieve.
You talk a little bit about underserved and public health initiatives, and you are unique in that you have an MPH. One of the articles that I read that you've authored was a landmark study that you did, I think probably 6-7 years ago, on public health training and internal medicine residency programs. And this is kind of known as the first complete categorization of public health training in internal medicine residency programs, where you noted that there's this wide discrepancy between the training that's provided, but yet, even though the resources are available, many students don't really get access to them. I thought you said like less than 10% of the students actually participate. And now the time we're in is really a public health crisis, COVID-19. So can you take me from your base experience in public health training, or the lack of in residency programs, to its impact at times like these, where that training seems to be critical and essential to being able to perform a good job?
At the time that we wrote that article, you're absolutely right. I think one of the challenges whenever you try and do research like this into public health is that is a pretty broad phrase. People will use the term public health to refer to a lot of different things, a lot of different parts of curriculum that they may be doing. And so, we found that many people will say we're teaching public health in some capacity. When you then ask them to pick, between these topics, what are the things that you're picking, you actually found a lot of sort of discrepancies there between what people were actually doing. And then to your point, most people had this kind of small focus for, the few residents who are particularly interested can really dive into this, but most of our residents don't receive it. I have to say, for me, I think between COVID and the sort of newfound interest and new awakening of interest in social determinants of health, I think is really making everyone realize this is part and parcel of being a physician. This is something that we need to think about as part of residency training. I do think there is an important role for public health professionals, and I personally would not suggest that physicians should be replacing those people. I don't think we need to become the public health experts who are actually carrying out and doing all of that amazing work that they are doing, but I do think we need to understand it. So just thinking, I think, more broadly about who should be on our teams. And, again, I'm not the person who's going to be that attorney, right? I will never be that specialist. That's not consistent with the role that I play on the team. But I may discover that information and that's a barrier for my patient's health. And how can I get them to the right person who can help with that?
A lot of times students have these thoughts, right? Should I do an MPH? Should I not do an MPH? You've done one. How should students make that determination?
I think the reason to potentially seek master's level training is that you're looking to build a particular skill set, or you're looking to learn more and dive more deeply into a particular topic. So I would say if that describes you, and if you want to learn more about epidemiology, more about health policy, more about social determinants of health or global health, then I think that is a really neat way to do it. I think it's more if it's of personal interest to you to learn that set of information or that skill set, I would say to do it. I certainly don't regret it. I thought it was a really, really great experience for me, but I don't think I can say because I had that degree, I got a particular job or something like that.
So let's talk a little bit about residents now. And you're leading one of the largest programs. I mean, you have 110 residents that you're responsible for training. You're going through all these different personalities and habits and traits. If you were to synthesize that into a few traits and habits that you've seen in the most successful residents, what would they be?
I think the most successful residents, and this applies to the most successful medical students, are really proactive in their learning. And I think that's a hard switch. All of us, we went through college, we went through the first 2 years of medical school that were, mostly desk-based in a classroom. And we're used to people telling us what we're supposed to read or telling us what we're supposed to look up. And then you make this huge shift when you enter the clinical part of your training and your career. And I think those who make that shift most successfully are the ones who figure out, hey, it's actually my job to generate the questions now. There's not someone else who's going to tell me, which book to read or give me a test of what those questions are. I also encourage my residents, when they have finished reading something, to pull out a sheet of blank paper and a pen and actually write like a fake assessment and plan for a patient who has that problem. Because that's the way we're actually going to use that information. So I think it really took doing that for me to realize it would be much more useful for me to write down something that is an active
way that I will truly use the information, which is, making a fake assessment and plan. I might even reference that the next time I have a patient who has that problem. Or even if I don't, it's just the act of having thought through the information in that way.
If there was one thing that you wish you knew when you entered medical school or residency, which you now firmly know is the key, or the one thing that you have total belief and faith in, but that you may not have had when you started this journey, what would that be?
I think what's become more and more clear to me throughout my career is the importance of reflection, and really, I would say non-judgmental reflection. And I think that's important in things both large and small. When I think back to the Jill Catalanotti who started medical school, I don't think she was a particularly reflective person. I think she was efficient and enthusiastic and, so could sort of learn information and memorize it and do well on tests. But I don't think she was particularly reflective. And I like to think that has changed a lot about me over time as I've realized the importance of it. But, for me, it comes in so many forms. So one is reflection to just think about, what does a successful career mean to me? Right? And therefore, what sorts of trade-offs will I make to head in the direction of how I have defined a successful career? I think reflection also about what is the field that I want to go into? I think there's such a role for regular reflection to say, what is important to me? What did I do well? And what do I still need to work on to get to those things that are important to me? What are the barriers that are getting in the way of that? Maybe I have to cut out some activities or things I'm doing because they're not leading to the path that I want to go on. My residents, unfortunately, know that this is a practice I have, that every evening before bed, I will reflect on the day and think what went really well today and what could I have done better today.
This was very insightful, Dr. Catalanotti, and I'm very appreciative of you giving us the time to learn from you and to really imbibe and start to practice some of these tools, like celebrating our patients' birthdays and spending time in learning their stories. And this has been great. Thank you so much.
Thank you so much. This has been such a fun time talking to you. And I hope that, if anyone takes away any pearl that's useful to them, then I'll be happy for having helped someone in that way. But it's great to have been mentored and be a mentor. And I hope everyone else can have those experiences too.
To our audience, thank you for tuning in with us here on the Medicine Mentors. Thank you for joining us as we learn from the masters in medicine.